Hello everyone and welcome to today's webinar. This is Giovanna Papa from the Vattikuti Foundation in Detroit, Michigan. And it is our pleasure and privilege today to have with us Dr. Anupama Bahadur and Dr. Lavanya Kiran. And they will host a program dedicated to women, a woman's journey from adolescence to menopause. And so before we start, if you have any question, you can type them in the Q&A chat box in the control panel. Our expert, they will try to answer to everything at the end of the program. And now, without further ado, I will turn it over to Dr. Kiran. Thank you.
Good evening, everybody. We are very glad to host this session. And I'm glad that I'm moderating my dear friend, Dr. Anupama Bahadur. Today, she'll be talking to us and taking us through a woman's journey from adolescence to menopause. You all know, as a woman, we go through so many things. There are so many emotional, physical, mental trauma which she goes through, and there are so much variation in a woman's life that she has to pass through from adolescence to menopause. So here is Dr. Anupama, who will help us to understand how this journey goes along. How do we handle these women when they come to us? And let me introduce my friend, Dr. Anupama Bahadur. She has always had a special interest in reproductive medicine and minimal invasive surgery. She is a very good robotic surgeon and indeed a very nice human being, and that is what makes her a good doctor. She's been interested in high-risk pregnancies. She's been the Vice Dean for the Social Outreach Program. She's been an ex-Vice Dean on the academic, and she heads the robotic surgery. She's also the unit head of the Department of OB-GYN at AIIMS Rishikesh. She's been the secretary of IFS chapter, and then she has received several awards for herself, like Corion Award, and then she's received the first gynec robotic surgeon of AIIMS Rishikesh. She's been known for that. And she's also received the Best Teacher Award in 2018 and 2020. And she's got Himaratna Award for her noble work in the field of health services. And she's received an award from Governor of Uttarakhand in Jan 2020. She's also been awarded her Seva Ratna by the Honorable Chief Minister of Uttarakhand for her social services. She's done a lot of presentations in the national and international level. She's received several certificates for her wonderful robotic surgeries. And she has a huge fan club in the patients crowd herself because she's really a good surgeon as far as I know her. Over to my dear friend, Dr. Anupama Bahadur, and I'm sure she's going to do a great justice on this women's journey from adolescence to menopause. Over to you, Dr. Anu.
Thank you so much, Lavanya, for that wonderful introduction. At the outset, I'd like to thank Dr. Bhandari for giving me the opportunity and the platform to present a woman's journey from adolescence to menopause. Thank you, sir, for making us women feel so special. Well, women are an integral part of society, and they are the ones who ensure that life goes on. So the journey of a woman is wonderful, yet complex. Right from being a child to a teenager and later a woman, the female body undergoes innumerable changes. However beautiful and significant these changes might be, there are certain underlying causes that affect one's physical as well as mental health. And more often than not, we as women accept these changes rather than trying to make an effort to understand and adjust the body towards these change. So, a woman is the full circle. Within her is the power to create, nurture, and transform. In her and through her, a life is born. So here I am to present an ode to a woman's journey. Whenever a baby girl is born, there is every reason to celebrate. There are major landmarks in a girl's life, starting from puberty, which is attained at menarche and occurs between the age of 10 to 16. Adolescence is a time of uncertainty, which is stuffed with expectations and glazed by rebellion. I'm sure you all have adolescent girls and you have adolescent boys at home. So a girl goes through different changes. It starts with a breast bud, followed by axillary and pubic hair. The acne at times are worrisome for her. And then she attains menarche or comes of age. The reason that I've shown this pad here is that there are several myths during puberty, which we will debunk one after another. In a country like ours, women still use cloth pads, which can cause, they are unhygienic and they can be harbingers of certain infections. So the government of India launched the menstrual health scheme in 2011, and there were 6 pads being given for 6 rupees. That is 1 rupee a pad, that hardly amount to anything if we convert it into dollars. And these are distributed by ASHA workers. The reason is that they want to stress on menstrual hygiene. In fact, in our country, we even had a movie being made which was called Padman to spread awareness about menstrual hygiene. There are several myths in a girl's mind. Puberty will make me look ugly because she gets these acne, and in case she's PCOS, then there may be hirsutism as well. But then they must realize that it's only a transitional phase and is bound to end up well. They often think that menstrual blood is bad blood. But then let us know that there is no impurity in blood that is being shed during menstruation. The uterus is actually being prepared for the next menstrual cycle. Another myth that they have is menstrual bleeding makes women unhealthy and weak. But the fact is that if you have an adequate diet, which is rich in iron, and stay healthy, then this doesn't really matter. We have a lot of women, mothers, who come to us with their teenage daughters, and they are diagnosed as polycystic ovary syndrome. At this juncture, it is very difficult to actually tell them about their irregular cycles, their acne, their hirsutism, because this can be normal as well. But in case they have weight gain, then a vicious cycle develops. Hirsutism and acne more than usual is definitely a cause to worry. And this is the time when we need to catch them young, when they need an early gynecologist consultation, because later in life, once they get married, they're more prone to infertility. And when they are in their perimenopausal state, they might develop diabetes, cardiovascular diseases, they're prone to hypertension, metabolic X syndrome. So all that can be prevented if we start talking about lifestyle changes, weight loss, etc. to them at this juncture itself. Another important thing is to teach these young girls about sex education. I'm sure most of you have talked about good touch and bad touch when they were young and little girls. But then once they reach adolescence, they think it's time to explore. And whom should they approach for their doubts and queries? And in case they develop any sexually transmitted infection, then what do? Plus, there is always that risk of becoming or having an unwanted pregnancy. Well, if the pregnancy continues, then since she's a teenager, she may have anemia, there may be high blood pressure, mentally she may be stressed out, there may be intrapartum complications like low birth weight, prematurity, the baby may be stillborn, and if born alive, then there may be lack of neonatal care. These girls, since they have to look after this young newborn, they may be school dropouts, they have lack of family support, and often community discrimination. But then we need to educate them. We need to tell them that they need dual protection. We need to tell them that condoms should be used along with the preferred birth control to protect against sexually transmitted diseases. They have the option of oral contraceptive pills, but a dual contraception is always better. IUD and implants are there and most effective, but then not widely used by these teenagers. However, if they get pregnant, please remember that they are not being judged by us obstetricians, and they do have the option of emergency contraception in the form of I-pill or levonorgestrel pill, which is sold over the counter and is effective if taken within 72 hours of unprotected intercourse. There's another one called ulipristal acetate, which, if taken within 5 days of unprotected sex, can prevent an unwanted pregnancy. USP regime and intrauterine devices are also there. However, if pregnancy continues, then it's legal to abort. They may continue with safer practices, and always remember to consult your family physician. Do not hesitate to seek support of your parents, of your loved ones, and open up. But then every time she misses a period, she doesn't have to worry or think about pregnancy only. She may be having polycystic ovaries, or there may be other factors like mental stress, physical stress due to excessive exercise, rapid weight loss or weight gain, and chronic illness. All this is because of a hypothalamic shutdown. And if the stress factor is removed, then regular menses are restored. Now we come to a very, very important topic, and that is HPV vaccination. Just like the world over is talking about COVID vaccine, for young girls, there is HPV vaccine to protect them against cervical cancer. And a word about this German virologist, Harald zur Hussein, who won the Nobel Prize in medicine in 2011, because he discovered that papilloma virus is the causative agent in cervical cancer. This has led to a sea change in outlook towards cervical cancer. So it would be best to vaccinate these young girls between the age of 11 and 12 years. At that time, 2 doses will suffice. And if you do so at a later age, that is between 15 to 26 years, then they require 3 doses at an interval of 0, 2, and 6 months. Now, we have Gardasil 9 that protects against 9 HPV virus types, which of course is not available in India. In India, we have Gardasil 4 and Cervarix. So an early dosing schedule gives maximum effectivity due to lack of sexual exposure. Thus, we must remember that an ounce of prevention is worth a pound of cure. In fact, even the WHO and world over are implementing HPV vaccination as the primary prevention for cervical cancer. And according to them, the 2030 goal is that 90% of girls should be fully vaccinated against cervical cancer by the age of 15 years. So all parents who have teenage daughter, it is my earnest request to please go meet your physician, meet your gynecologist, and get your daughters vaccinated against HPV, since it is the causative agent for cervical cancer. All women who are in the age group of 35 to 45 years, they must be screened for cervical cancer. The screening process is very simple. We do a pap smear in the OPD, which hardly takes 2 minutes. And in case you have a positive cervical screening, then you need to receive treatment for it, because the earlier that cervical cancer is diagnosed, the better your prognosis will be. So the world over on 17th of November celebrated a day where we will see a world without cervical cancer, and in fact, the mortality should be brought down to less than 3%. Now, after talking about cervical vaccine, once she enters adulthood, it is not an age, but a stage of self-knowledge. So let the knowledge prosper. Women generally come to us as adults with menstrual irregularities and premenstrual syndrome. So what is menstrual irregularity? In case your periods are coming in less than 21 days or more than 35 days, or in case you bleed more than 80 ml per day, that is you're fully soaking pads and tampons at least 4 to 5, then we consider it heavy menstrual bleeding and irregular bleeding. But most of the women, they come to us with premenstrual syndrome. You can't label all women with premenstrual syndrome. You have to look at the affective symptoms and the somatic symptoms. In case she has these angry outbursts, she's anxious, has confusion, or is depressed, irritable, socially withdrawn, with somatic symptoms as well, like abdominal bloating, breast tenderness and swelling, headache, joint and muscular pains. And these symptoms are not being relieved within 4 days of onset of periods, and they don't recur at least within 13 days of the cycle, then we need to see and treat them. So premenstrual symptom, this can be cured, and women can always come to us in case they have any of these affective or somatic symptoms. Being a gynecologist, I'm a very proactive person and feel that we need to treat rather than a reactive person. When we have women coming to us for pre-marriage counseling, we generally do a genetic counseling. We give them mental support and talk about the sexually transmitted infection and how they can prevent it so that they don't get infertile later, because some of these sexually transmitted infections can go and actually block the fallopian tubes. In case they come to us with preconception counseling, we need to check their BMI, that is body mass index, and see if they are either obese or underweight, or they are morbidly obese. And this is the time when we need to tell them to lose weight, because a high BMI is associated with a lot of pregnancy complications like hypertension, diabetes, etc. Well, we need to check into their family history and know if there is any genetic disorders. In case they have any nutritional anemia, they have hypo or hyperthyroidism, which can be detrimental in the course of pregnancy, we need to correct that as well. This is the time when we can talk about folic acid and the neural tube defects, and we can start these women on folic acid preconceptually 3 months before they plan a pregnancy. We do rule out diseases like thalassemia and rubella. In case she's rubella non-immune, an MMR can be offered to her. And if they receive MMR, then they should avoid conception for at least 1 month before they try for conception. At every step, a woman should be taught about contraception counseling. And that is important because we don't want them to land in septic abortion. They must be taught about the cafeteria approach and whatever is best suited for her according to her age, according to her lifestyle, according to any disease that she's harboring must be offered. Plus, it is important to teach them about the importance of a planned pregnancy. However, not every couple is lucky, and some do go through infertility. But remember that it's not just a woman who is to be blamed for not bearing a child. There can be a male factor infertility, and there can be a combined infertility, that is an unexplained infertility. So this is the time when they can come to us, and the solutions are always there. So if you're proactive, you need to go through their entire history. You need to find out the cause of their infertility, since science has progressed so much that now we have IVF baby who's more than 40 years old now. So they can be offered the option of ovulation induction, intrauterine insemination, and in vitro fertilization. So if they are lucky enough and they conceive, it is the time to take care of a woman and her baby. There comes the role of antenatal care. Up to 12 weeks, they need to be registered. It is absolutely delightful for the couple to see their baby's heartbeat on the ultrasound screen while the ultrasound is being done. And initially we do it as a dating scan along with a dual marker. So folic acid, if they are taking, must be continued. They must be screened for all known health risks. Once they come up to 20 weeks, we need to do an ultrasound again. That's an anomaly scan along with quadruple marker. They need to be started on iron and calcium and vaccinated. All routine investigations must be checked now. So as pregnancy progresses, there are several tests that need to be done, like glucose tolerance test and echo if it is indicated. By the time she enters her 3rd trimester, we need to regularly monitor her blood pressure, look at her sugars, talk to her about her daily fetal movement count, And in case she has any bleeding or decreased movements or pain abdomen, she must report immediately. Plus, by the time she's 36, 37 weeks, a pelvic assessment is necessary, along with talking about the mode of delivery and stressing on the fact that institutional delivery is to be encouraged so as to prevent any maternal complications and any neonatal complications that arise. Now, by the time she has a family, she's more concerned about her children, about her husband, and she hardly takes any care of her own health. She may come to you with abnormal uterine bleeding, wherein, according to PalmCoin, there can be either a structural or a non-structural cause. There can be polyps, there can be a fibroid, malignancy can be very scary, then there can be any thyroid disorder or prolactin disorders, there can be some coagulation disorder, or if you've put in an intrauterine device, then that may cause irregular bleeding, etc. So we need to evaluate her, we need to offer her medical therapy for her abnormal uterine bleeding. Normally, AUB or her this bleeding is controlled with medical management, but in case her medical management fails and she insists on getting a surgical management, then of course we can offer her an abdominal procedure, that is an open procedure, a vaginal procedure. And now we have minimally invasive surgeries which have really revolutionized the entire course of surgery for women. And of course, there is the robotic surgery that has come up. I'm a great proponent of robotic surgery, although cost is an issue. When we sit in the OPD, we do have women who come to us with primary ovarian insufficiency. These are the women who would be less than 40 years, and all of a sudden their periods have stopped. Initially, they think it could be because they are pregnant, but then we need to evaluate them. So they may even come to us with difficulty in getting pregnant and may have symptoms like hot flushes, night sweats, vaginal dryness, irritability, and decreased sexual desire. So we normally get their blood tests done, that is a follicle stimulating hormone levels. And in case it is in the menopausal range on at least 2 occasions, 1 month apart, with amenorrhea, at least for 4 months in women who are younger than 40 years, then a diagnosis of premature ovarian insufficiency is made. And once this diagnosis is made, they need to be started on HRT after a thorough evaluation. The scariest part is malignancy risk. It's not just that malignancy comes only when a woman gets older. It can be there at any stage in life. We have seen young girls, teenagers in their early 20s, 30s, 40s, developing some kind of genital malignancy, be it uterine cancer or cervical cancer or even ovarian cancer. So we need to educate them about all these malignancy. We need to tell them that in case they develop any of these malignancy, they need to get themselves screened and come to us early. So talking about breast cancer, a self-breast examination should be done by all women, after their periods, 2 to 3 days after their periods, every month. In case there is any suspicious lump, then a surgeon's opinion must be sought. Well, if they are in the age group of 20 to 40 years, they need a clinical breast examination as well as mammogram. And beyond 40 years, a clinical breast examination as well as mammography should be done yearly, because early intervention gives us a better prognosis. In case there is a family history of PICA 1 or 2, then screening must start early. Prophylactic mastectomy should be done. And please do not ignore a lump. So breast cancer is something that is preventable. By screening, we can pick it up early. Self-breast examination is something that every woman should do after their periods. The other thing is cervical cancer. Now, as far as cervical cancer is concerned, I've already spoken about primary prevention in the form of HPV vaccine. However, in case she has not been vaccinated, then from 25 years onwards, she must get a pap smear done and even have an HPV co-testing done every 5 years. This is just a routine OPD procedure. It hardly takes 2 minutes. It's cost effective. So this comes under secondary prevention. In case you have anything like a postcoital bleeding, please do not consider it normal, because the virus can be causing havoc and awareness is the key. So in case cervical cancer is picked up early, then the chances or the prognosis is much better, as vis-a-vis if it is picked up in the late stages, that is stage 3, where surgery is not possible. They need to go in for chemotherapy, radiotherapy, and there are several complications. Now, talking about the endometrial cancer, routine screening is not indicated until and unless there is Lynch syndrome. However, if there is postmenopausal bleeding, if the woman is obese, hypertensive, diabetic, plus there are other factors, then she needs to be screened. She can get a transvaginal sonography and we look at the endometrial thickness, depending on whether she has hit menopause or she's coming to us before menopause. So depending on the cutoff for the endometrial thickness at that point of time, she can be evaluated and a biopsy can be taken. The scariest of them all is ovarian cancer, since it presents much later in stage 3, and nulliparity is a risk factor. Oral contraceptive pills are protective. However, BRCA1 and BRCA2, in case she tests positive for it, then she needs to be evaluated further. In case we are doing a hysterectomy, as far as for benign indications are concerned, generally we perform an opportunistic salpingectomy, because they say that the ovarian cancer is spread through the fallopian tubes. So at this point of time, when we're removing the uterus, we can remove the tubes as well. Fertility preservation is coming up in a very big way, because we see young girls, young women, developing cancer, and they come to us with oocyte preservation. That is, in case there's a young girl who's not married, she can preserve her eggs. If she's married, then we can talk to the couple about embryo cryopreservation and doing an IVF later on. Well, this is important that we do a radiation shielding and ovarian transposition. That is, the ovaries, they're removed from the field of radiation. Now, in case she has endometrial cancer and she wants to delay a definitive treatment, a medical management can be offered. Plus, in cases of, say, cervix, early surgical saviors in the form of trachelectomy or unilateral oophorectomy is there. However, if these are not the options, then the option of surrogacy remains. So having gone through all this, we come to menopause, which is just puberty's older sister. Women at this stage come to us with vasomotor symptoms. 2 million women in the US, they reach menopause each year, and 75% experience vasomotor symptoms during this menopausal transition, that is from perimenopause to menopause. And this duration of vasomotor symptoms is as long as 7 years. So I don't think, as gynecologists, we can let these women suffer for 7 years. Now, whether hormone replacement therapy is a boon or a bane, well, this can be dealt with by your gynecologist after looking at your entire health profile, doing a health checkup, knowing your health risks. And this is the time when protection of estrogen is lost. So there is increased risk of cardiovascular diseases. Women are at a risk for fractures. They can be offered hormone replacement therapy after discussing with the gynecologist. In case they have dryness, vaginal dryness, then we can give them topical therapy in the form of estrogen cream. We can give them things for vaginal lubrication, which don't have any systemic side effects and also help in urinary symptoms. The advantages of HRT is that it relieves symptoms, prevents fractures, it keeps the cardiovascular system protected, but it has its own disadvantages as well in the form of thromboembolism. You can throw an embolus. There is a risk of stroke. Remember that breast cancer and endometrial cancer, well, there is a query and we need to look into it. So please do not take hormone replacement therapy just because your neighbor is taking it, or you've just heard somebody who's on HRT. Until and unless you meet your gynecologist, she evaluates you, gets your mammography done, gets a pap smear done, rules out your diabetes, hypertension, etc., and finds that it is a safe option for you, only then take HRT prescribed by your doctor. Another worrying symptom is postmenopausal bleeding. So once periods have stopped and suddenly a woman sees a red blood, on her panty, then she has every cause to be worried, because it may be benign or it may point out to a malignancy. Please do not ignore postmenopausal bleeding. So it is a cause for worry. There can be atrophic vaginitis. There can be, the endometrium or the lining undergoing atrophy. There may be a polyp or endometrial hyperplasia. But what is concerning and what is alarming is there endometrial cancer? Is there a cancer of the uterus, or is there a cervical cancer? Because if she has cervical cancer, she may present with a dirty discharge. She may present with foul-smelling discharge. She may have bleeding. She may have postcoital bleeding. And these are not things that we can just take lightly. So she needs to be evaluated. For an endometrial cancer, we can do a transvaginal sonography, look for the cutoff. If she has attained menopause, then if it is more than 4 millimeters, well, we can do a hysteroscopy if available and take a biopsy. We must keep a high index of suspicion and follow them up with appropriate biopsy, and whatever the histopathology report is, then the treatment begins. If it comes out to be benign, well, that's good. She's lucky, but in case it doesn't, then depending on the diagnosis, the management starts. Loss of libido is also something that is concerning to a woman, since there is a decrease in the ovarian hormones, and it can cause stress, anxiety, depression, relationship disturbances. Well, all this can be handled by going to your gynecologist and talking about it, and she may prescribe the treatment for it. So she takes care of the entire family's health at the cost of her own. She thrives for the better livelihood of all, and her health pays a price for it. She who embarks on this journey alone, at every juncture fights hormones and avoids health crisis. She may falter, but never fails, and awakens for self-care when postmenopausal and frail. She must be rewarded, pampered, and taken care of, because she defines generations. Well, the journey would be incomplete without thanking the pillars of my department, the residents, the faculty, and of course the patients, because you are the signature of my journey. And we must find time to stop and thank all the people who make a difference in our lives. Thank you, Dr. Bhandari, for giving me this opportunity and talking about women, which are very, very dear to my heart. And that is why I think I became a gynecologist. I thank you profusely, sir, for giving me this platform today. I'd like to thank Dave and Giovanna, who've been there to help me from the inception to conception to delivery of this webinar. And I'd like to thank Dr. Lavanya, my friend, who's been very, very encouraging. Thank you.
Wonderful, Dr. Anupama. I think you have done an excellent job, I should say. So excellent that we have no questions. I think really a great job that you have done. I love the way that you went in such a meticulous way from puberty, how you told us about what happens about her puberty, how do we maintain hygiene? And then I loved how you stepped into reproduction and then contraception. You did cover on the oocyte preservation, and such excellently done, and gracefully you moved on to the menopausal state, and I think it was beautifully covered. You touched on everything that was so important for us. Wonderful. I would like to congratulate Dr. Anu for such a fantastic job that she has done. And I would take this moment, like she mentioned, we need to thank everybody. I think the most thank yous should go to Vattikuti Foundation for this wonderful opportunity given to me to moderate my own friend, Dr. Anu. Thank you, Dave. Thank you so much. Thank you, all the people in Vattikuti Foundation, and especially Dr. Bandari, who's been so encouraging, so much standing behind us like a pillar, supporting all of us to do such a wonderful job. I think I enjoyed every bit of your talk, Dr. Anu.
Thank you. Thank you so much, sir. And thank you, Lavanya. Thank you, Dave, and thank you, Giovanna, as well as all our patients, all my friends and relatives who've been there and who've joined us on the webinar today. Thank you.
Thank you very much, Dr. Anupama. It was a wonderful discourse, as Lavanya has already told that even there was something for me to carry over, because my granddaughter is 11 years old and I'm going to get HPV done vaccine for her. So medicine is so deep and vast, and only thing I would say that one, you have tickled our memories of Pondicherry meeting by putting up this photograph.
Yes, sir.
And that was wonderful. I would like to tell those who are participating that Vattikuti Foundation has multiple target audiences to address, and we need to organize ourselves. And for 2021, when we bid ADU to this COVID-19, we proposed to have 3 target groups, which I would let you know. And since these 2 excellent gynecologists and great friends of the foundation, I would like to have a feedback. We want to target the patient education on top, because whatever we do B2B between us ultimately benefits patient, but we need to continue patient communication. So we would like to call upon patient webinars, and Gianna and Dave are working hard to build a patient clientele, because our branding is mainly with the surgeons and robotic surgeons and cutting edge specialty hospitals. Second target we want to do is educating a non-academic or practicing specialist, maybe gynecologists, urologists, and something like that, because they need a continued education. Particularly, I can compare India and US, because here there is nobody academic. Until you do your credentialing and re-credentialing, you would not continue to practice. But India, you obtain certificate for once and then it's a license for the rest of the life. So we want to continue doing what we are doing, middle order. And the third thing I want particularly Anupama to know and Lavanya to know is that we want to do focused postgraduate teaching master classes.
Yes, sir.
And these are the subjects which are not usually they learn, but and for that we would be restricting the number of participants and increasing the time of interaction. The initial thing would be a 2-hour master class wherein we will bring the expert who would talk the least 20 to 25 minutes. And then most of it is interactive thing, so that really they can feel involved and get the answers. I am still debating why I am giving this discourse is because I am taking this as an opportunity to get a feedback, because I have learned in one life that there is a term in our times we used to use a slidoria, that in order to satisfy, the speaker would have 100 slides to present without bothering about the poor audience. And my firm resolve is that I don't want to deliver anything which does not benefit the target audience. So the postgraduate should feel benefited, that they cover up questions for their exams. They learn something which ordinarily they would learn, and then they carry it over to practice and develop interest in particular thing. So there could be two directions we can take. We can bring esoteric subjects, like what are the recent advances in a particular kind of thing, and what are the current concepts on that, and we bring the best of the intellects in that particular subspecialty or subject. And foundation has an advantage of a very large network of its friends across the globe who have helped us to establish programs in India and other places. And the second thing could be that we bring in something which is very, very controversial and needs to be redressed in terms of concepts and all, because it's so hard to keep a pace. So I would like to invite all of you to think about and give your proactive feedback. Otherwise, I'll get back to you. Anupama and Lavanya, both. If in life, understand one thing: if you do something good, you are in trouble. If you are not doing something good, you are anyway in trouble. So I look forward to involve you more and more next year, because both of you have done excellent jobs in delivering what was anticipated, or more than what was expected. Thank you very much once again, sparing your Saturday evening in India.
I've always appreciated you for the way you think. You know, I don't know how a CEO can think about a patient per se. I mean, that shows your highness, and then such humbleness that you want to target and help the patients as well through the educated surgeons, learned surgeons. I think your thoughts are always a big encouragement to us, and then you always put a stepping stone for us. So we'll definitely put our thinking hats on and start thinking, and how do we stand behind you and make this program a success.
Always there for you, sir. We'll do our best for whatever you give us. Thank you so much.
And always there is so much. I know that you are great learners, but there is always a learning for us. And I have found, one fact, that I have a very bright PhD in economics, one of my cousins. And she is did from Brown University, a very bright candidate. And I asked her a few months ago. He said, I teach in a primary school. I said, you've gone crazy. I thought you would be a professor in the university. He said that you are very naive, that they take the best of the students to teach economics to the youngest. And that shows that how difficult it is to convey subject for a specialist to the real patients who can understand every word. You have to be careful. What do? You have to bring it down to that level. It's so easy to talk to your students who already have a knowledge, but it's very difficult to talk and make sense for an audience which is general. So I think it's a great a mutual learning experience, and we look forward to continue that.
Yes, sir.
Hello, everyone. This is Dave Meinhardt in Detroit with the Vattikuti Foundation. Thank you so much, Dr. Anupama and Dr. Kiran, for this wonderful presentation today. It was very, very well done. And
thank you, Dave.
I learned a lot myself from this, and having a daughter and that it's important information for parents and for women especially. And you did a lot to inform people today. This video will be available on our Vattikuti Foundation website next week, probably about Tuesday, if all goes well. It takes time to get everything put together. My thanks also to my colleague Giovanna Papa, who introduced the program today and did a wonderful job. She does a lot of the work making these webinars possible. And so with that, we'd like to tell everybody to thank you, and we will have another program next
one
year.
thing, Dave, I'd like to thank Dhriti. She has helped me a lot with this webinar, and I think it would be incomplete without, bringing her live on this session. So thank you, Dhriti. You've been a great support.
Thank you.
That's really nice. You know, if we wouldn't do this without help from others. That's the important thing to note, is that, you know, it's a team effort. And
Yeah, I feel I can't do anything alone. I work in a team. I believe in teamwork.
Well, it's always nice to talk to you and to work with you, as we have for some time over the years now, Dr. Bahadur. And I appreciate all that you did today to prepare for this. So with that, I think we're going to say goodbye.
Thank you,
Dave. Thank you, Jyoti. Thank you, Anu. Thank you, Papa. All of you. Thank you so much. Have a good evening. Bye-bye.
Thank you, everyone. Thank you so much.